Welcome to this MSRA Masterclass Explainer. Today, we're jumping right into cracking the code of pulmonary function tests and spirometry. You know, if you've ever felt completely overwhelmed by all the numbers, the ratios, or those notoriously tricky flow-volume loops, you are in the exact right place. We're going to break the whole thing down step by step so you can tackle these clinical concepts with absolute confidence. Let's get to it. Here's our roadmap for today's clinical bootcamp. 1. The diagnostic gatekeeper. 2. Obstructive versus restrictive patterns. 3. The ultimate comparison table. 4. Decoding flow volume loops. And 5. 10 essential MSRA questions. All right, Section 1. The diagnostic gatekeeper. Mastering the fundamental ratios of spirometry. Okay, let's dive into this. The absolute crucial point you need to grasp here is the FEV1 over FVC ratio. This ratio is basically the core physiologic principle of all spirometry. It's a volume-time measurement that's incredibly critical because, honestly, it serves as the golden rule for classifying a patient's breathing defect. It's that literal fork in the road that tells you, hey, are we dealing with an obstructive pattern or a restrictive pattern here? And here is the magic number you need to burn into your memory for exam day: 0.70. If this FEV1 over FVC ratio is less than 0.70 or 70%, you're looking at a diagnostic confirmation of an obstructive defect with airflow limitation. Boom. Done. However, if that ratio is 0.70 or higher, but the total forced vital capacity, the FVC, is low, well, that points you directly toward a restrictive defect. Keep this rule in the back of your mind. It's the foundation for literally everything else we're going to discuss today. Moving right along to Section 2, Obstructive versus Restrictive Patterns, Understanding Pathophysiology and Spirometric Hallmarks. Let's really contrast these two main patterns. First up, the obstructive pattern. Pathophysiologically, this is all about airway narrowing and dynamic hyperinflation, which basically leads to air trapping. Because the air just can't get out fast enough, you see a disproportionate drop in FEV1, dragging that golden ratio we just talked about right below 0.70. Now compare that to the restrictive pattern. This is entirely an issue of stiff, non-compliant lung parenchyma or chest wall restriction. The lungs physically shrink in total volume. And because of this, both FEV1 and FVC drop in tandem. Since they're dropping together, the ratio actually stays normal or can even go up. You absolutely must memorize these classic examples for the MSRA. For obstructive diseases, think of conditions where the airways physically narrow. We're talking asthma, COPD, bronchiectasis, and alpha-1 antitrypsin deficiency. Now, for restrictive conditions, you've got to think of things that restrict the actual physical lung expansion. Things like idiopathic pulmonary fibrosis, asbestosis, and anatomical restrictions like scoliosis and obesity. Recognizing these disease types instantly is going to save you so much valuable time on the test. Section 3, the ultimate comparison table. High-yield spirometric parameters side by side. This comparison table right here is an absolute gold mine. We've got FEV1, FVC, and the ratio mapped out across normal, obstructive, and restrictive states. But listen, pay super close attention to the transfer factor, or TLCO. This is measuring gas exchange, and notice how it behaves. It actively drops in emphysema because of alveolar destruction, but it stays totally normal in asthma. That is a huge distinction. Meanwhile, in restrictive diseases like IPF, it is significantly reduced because of that thickened alveolar capillary membrane. Spotting this TLCO difference is a massive differentiating clue for those tricky exam questions. Section 4, decoding flow volume loops, visualizing the fingerprints of airway obstruction. These loops basically plot airflow rate against exhaled and inhaled volume. I want you to visualize these loops as unique fingerprints for specific pathologies. For a lower airway obstruction, something like asthma or COPD, you're going to get this highly characteristic, heavily scooped out, concave expiratory curve. But what if it's a fixed upper airway obstruction, say a massive goiter or tracheal stenosis? That actually creates a rigidly box-like loop where both the inspiratory and expiratory limbs are totally flattened. For a variable extracranial obstruction, the airway collapses completely inward during inspiration, so only the inspiratory limb flattens. And for variable intercranial obstruction, it's the exact opposite, just the expiratory limb flattens. Makes sense, right? All right, Section 5, 10 essential MSRA questions, testing your retention with rapid-fire active recall. Let's jump into question 1. What numeric FEV1 over FVC ratio threshold is universally utilized in standard spirometry to confirm an obstructive ventilatory defect? Think back to that golden rule we talked about earlier. The numeric threshold confirming obstruction is less than 0.70 or less than 70%. Here's our next scenario, question 2. A patient presents with progressive exertional dyspnea, bibasal Velcro crackles, and digital clubbing. Spirometry shows a reduced FEV1 and a significantly reduced FVC. So what is the expected FEV1 over FVC ratio? Well, for this restrictive profile, which is strongly hinted at by those Velcro crackles and that tandem drop in volumes, remember that the ratio actually remains normal or even increased, meaning it's greater than or equal to 0.70. Question 3. And watch out, this one is a classic examiner trap. If spirometry suggests a restrictive ventilatory defect, which specific lung volume must be measured via body plethysmography to formally confirm the restriction? The answer is total lung capacity, or TLC. You literally have to see that it is less than 80% of the predicted value to officially confirm that restriction. Moving on to question 4. Why might the forced vital capacity, the FVC, also drop in advanced obstructive lung diseases like severe emphysema? Now, while FVC is usually totally normal in obstructive patterns, severe dynamic air trapping and hyperinflation can actually increase the residual volume inside the lungs. This then encroaches on the vital capacity, causing the FVC to drop. Halfway there, question 5. What descriptive term defines the morphological shape of the expiratory curve on a flow volume loop in a patient with chronic asthma or COPD? Picture that flow volume loop for asthma we were visualizing a minute ago. The expiratory curve has that incredibly distinct, scooped-out, concave shape, and that's entirely due to flow limitation at low lung volumes. Let's tackle question 6. A patient with a massive retrosternal thyroid goiter undergoes a flow volume loop test. Which component of the respiratory cycle typically demonstrates flattening if there is a fixed upper airway obstruction? As we learned, a massive goiter creates a fixed obstruction. This brilliantly illustrates itself as a flattening on both the inspiratory and expiratory limbs, creating that completely box-like appearance on the graph. Question 7. In a patient with idiopathic pulmonary fibrosis, or IPF, what happens to the gas transfer factor for carbon monoxide, also known as the TLCO? In restrictive diseases like IPF, you have alveolar capillary membrane thickening and actual destruction, and because of that, the TLCO transfer factor is significantly reduced. Question 8. Following initial abnormal obstructive spirometria, what quantitative improvement in FEV1 after administering inhaled bronchodilators confirms reversible airflow limitation in asthma? Okay, to formally confirm asthma reversibility, you need to see an FEV1 increase of at least 12%. And this is the critical part, do not forget this, it must be both 12% and at least 200 milliliters after bronchodilator use. It absolutely requires both of those metrics. Almost done. Question 9. A patient with a vocal cord palsy presents with stridor. Which limb of the flow volume loop is selectively flattened? Well, vocal cord palsy is a classic example of variable extracranial obstruction. And what this means is the airway collapses inward during inspiration, thereby selectively flattening only the inspiratory limb. And finally, bringing it home with question 10. Name one acute clinical situation where performing a maximal forced expiratory maneuver, meaning spirometry, is strictly contraindicated due to rapid intrathoracic pressure spikes. Remember, safety first. You must never order spirometry if rapid intrathoracic pressure spikes could be fatal for the patient. This includes conditions like a recent myocardial infarction, unstable angina, recent eye surgery, a pneumothorax, or a thoracic or abdominal aneurysm. As we wrap up this explainer, I really want you to ask yourself a question. The next time a breathless patient walks into your clinic, are you going to be able to instantly visualize their flow volume fingerprint and use that golden ratio to unlock their diagnosis? You've got the foundational keys now, but what happens when mixed obstructive and restrictive patterns collide? Think about it. Keep reviewing those ratios, stay curious about the exceptions, and I'll catch you in the next one.